Dr. Lambrew brings a wealth of expertise, as you'll hear in my introduction and in what she shares with us today. She's currently Director of Healthcare Reform and a Senior Fellow at the Century Foundation, as well as an adjunct professor at Harvard. For the last 5 years, from 2019 to 2024, she was the Commissioner of Health in the state of Maine, and so led the Department of Health and Human Services for the state. And if you think about 2019 to 2024, it was a pretty active time in public health and health systems at the state level, so she was involved in all of that. Prior to that, she worked in the Obama administration. In the first 2 years, she was Director of the Office of Health Reform at HHS, and from 2011 to 2017, served as the Deputy Assistant to the President for Health Policy. Prior to that, she was in academics as an associate professor at the Lyndon B. Johnson School of Public Affairs in Austin, Texas, and prior to that at GWU, George Washington University in DC. And she's also been in the Clinton administration prior to her work in Texas, where she was in the Assistant Secretary for Planning and Evaluation within HHS, the White House National Economic Council, and the White House Office of Management and Budget. So she brings a wealth of experience, both at the federal level and at the state level. And without further ado, I'll let Dr. Lambrew share some of her experiences and thoughts with us.
Thank you so much. I am so grateful to be here. And as the introduction said, we're going to try to get through a lot of material in a quick period of time and leave 10 minutes for questions. Hold me to that. But the topic of this discussion is prospects for health reform in volatile times. Just to level set on this, as soon as I get the slides to work, there we go. The goals for this time are to, first of all, contextualize the health policy discussions that are happening today. So you hear a lot about then and now, as well as to distill lessons from the Affordable Care Act experience for future efforts. I do this from a perspective mostly of somebody who was involved. I was at the Center for American Progress before the law was passed, worked in Clinton administration on health reform. I was on the Obama transition team, Office of Health Reform in the first couple of years, and then at the White House. And that was implementation, passage, and defense. I also have done a fair amount of analysis and review of the law since then, but I am not a political scientist. I'm a health services researcher, degree in public health, so I take this all with a grain of salt. You have a whole lot of references. There are great books out there that you can look at to really get a good sense of the political science of this. So this is more of my experience and takeaways. What I'll do is, first of all, on the left-hand side of the slide, do a review. Really just try to contextualize what we're talking about in terms of health reform, looking at the past. I will try to do 15, 20 years of history quickly. We'll see how that goes. But then draw from that the things that people who worked on the Affordable Care Act were surprised by, lessons for future health reform, and why I think it's on the horizon. So to start out with, there are many different definitions of what is health reform. It could include quality and access to care, workforce. It could include equity. It certainly does include affordability. We'll talk about that a little bit. But primarily when people say the word health reform, they're thinking about universal coverage. How do we as a nation ensure that everybody has some sort of health coverage, right? And I just begin with this slide because we still have this debate today. Why does it matter? There are now decades worth of research studies that show, number one, having insurance improves your well-being, your reported health. People have lower rates of depression when they're insured, and they use care more. The slide and the chart on the right shows just the stark difference between people who have some sort of insurance, public or private, and who don't in terms of them seeing a doctor or health professional within the last 12 months. Being insured improves mortality. We have many studies, especially since the expansion of Medicaid under the Affordable Care Act, that document both lower all-cause mortality as well as cardiovascular mortality. And we even know that racial and ethnic disparities in healthcare often are caused by somebody having or not having coverage. In short, it matters. And it's not a new issue. Our history in the United States of trying to enact universal coverage goes back to the early 1900s. Teddy Roosevelt, when he had his Bull Moose Party, made covering everybody one of his platform items. FDR, Roosevelt, was kind of busy with other things like Social Security and World War II and didn't really focus on it. But after World War II, Harry Truman became a true advocate of trying to cover people. And that was because he experienced during the war young people, young men mostly, going to sign up for the military, being drafted, and being in such poor health that they couldn't serve. We had such a weak, rural, and underserved health system in the country. That was what motivated him. But interestingly, during World War II, because they were trying to get workers to build the planes and the ships and everything else, they used health benefits as a way to attract workers. So we created this employer-based health system, which is fairly unique in the world, because we were trying to get people to say, come to work, we'll give you free healthcare if you join our shipyard or whatever. So Harry Truman failed after much significant effort, but by the time John F. Kennedy became president, there had been a real increase in employer-sponsored insurance, but people who were older were left out. They retired, they didn't have jobs, they didn't have health coverage. So when LBJ became president and really pushed for his version of health reform, it became Medicare and Medicaid, which is they're both celebrating their 60th anniversary this year. After that, it was a long, dry spell for health reform. Interestingly, Richard Nixon was probably the next big champion. He had a family history of tuberculosis. His mother was a nurse. He just wanted to do something, but failed. And the last big effort after that was Bill Clinton, who actually ran on health reform. When he became president, he put Hillary Clinton, then First Lady, in charge of it. It failed. There's a long story there too, but it failed. But after that failure, the Republicans took over Congress and did the opposite. Newt Gingrich said we have too much spending on healthcare, tried to block grant Medicaid, tried to cut Medicare. He failed too. Out of that comes the 1997 Balanced Budget Act. And I mention it because in 1999, 2000, we actually had a balanced budget in the United States. First time in decades, last time in decades, but it happened in part because of the smart but serious Medicare cuts, as well as we use some of those Medicare cuts to create the Children's Health Insurance Program. That matters as we'll talk about the next chapter of this story, but I will say, and this is where we're really beginning the discussion, in the early 2000s, health reform was considered impossible. A third rail, it can't happen. Part of it is because the healthcare system was so big. I mean, how do you change something that is such a large percent of the economy? It was also because of health professionals' distrust of government. There were no professionals who supported health reform anytime before the 2000s, and it was out of concern that there would be some government interference in the practice of medicine. We also saw, especially in the Clinton health reform debate, this idea of the personal nature of healthcare. There were some ads run called the Harry and Louise ads, where there's a couple sitting around a table talking about how the concern they're going to be. How will this work for me? Will I be able to see my doctor? And it's because people are so passionate about having access to healthcare that change scares them. And it's easy for people who oppose that change to tap into that fear. And lastly, back in the early 2000s, people thought it was just politically impossible. We saw a realignment of some of the special interests. For example, the Chamber of Commerce should have supported health reform. Small businesses are hit hardest by the high cost of healthcare, yet they were against it for the political reasons of trying to get other things from the Congress, as well as kind of the political specter of socialism. There's an old ad that I need to go and memorize, but Ronald Reagan, before he was president, was an actor, and he was featured in the ads against Medicare, saying that if Medicare passes, that will be the sunset on freedom in America, or something very propagandish like that. That is something that was around then, is sort of still around now. So what did we do? How did we get to the Affordable Care Act? There was a lot of groundwork. Some of it was trying to develop a consensus on how to do it, building out what works, trying to prevent that fear factor that people have from health reform, trying to figure out what is equitable. I mean, it's hard to believe, but way back when, we had bipartisan agreement that the Medicaid program for poor people and people with disabilities, older people, should have a floor. There should be some nationwide minimum, so people in Texas, where eligibility remains at 15% of the poverty threshold for childless adults, is not, we don't want that compared to like a New York or a Massachusetts that actually were able to go above poverty. How do we create that floor? as well as create a private insurance system that works. The idea is fairly simple on private insurance. Create a three-legged system. Number one, our goal was to make sure that people with pre-existing conditions who need healthcare get access. They were being denied. They were having their conditions denied. They were having body parts excluded from their coverage. When you go back and look at what was going on in the 1990s and 2000s, it was pretty abhorrent. But give them access. But to give them access, you need to get other people in, so it's not just a very sick group of people. That's where financial assistance, oftentimes through premium tax credits or Medicaid, came in. Get people who are low income or young, who don't think they need it, but would pay something to get healthcare into the system. And then the third part of the system would be to say, if you can afford it, you have a responsibility to have health insurance. The fear that insurance companies had were, if somebody could walk in the door when they get sick and say, I want health insurance, and then sign up when they need it, and then drop out when they don't need it, you would have the same sort of just high risk pool sick system that is not going to actually work well for people. That requirement is often called the individual mandate, which we'll talk about in a bit. And the last part of the consensus development in the 2000s was affordability. We really have to make it affordable as well as accessible. We know if it becomes too expensive, kind of like it is right now, people will have an insurance card, but it may be meaningless. But at the time, we thought the only way to do that is really to try the kitchen sink, spread around that cost containment so it wasn't like happened in the 90s, all disproportionately falling on some providers. That was the consensus that was emerging. But we also needed to say it was important. It was an imperative. It was a priority. In the 2000s, the Institute of Medicine did a 6-volume report on the research that showed being uninsured is a public health threat. Why it doesn't affect just you, but your communities, your health systems, our nation. There was a lot of work done on the economic imperative. We really got budget people and economists to look at the drain on wages when so much money was going to health benefits and not income. We saw that there needed to be a moral imperative. I think one of the lessons of the Clinton health reform effort and failure was people didn't realize that it might be a good thing to be insured, that it might matter, that there might be some morality in saying that you shouldn't be able to turn somebody away just because they can't afford to pay. So there was an effort to engage faith-based groups. And in fact, the Catholic Health Association was a lead in that effort. But we also needed the grunt work, the advocacy, the coalitions. Back in the day, there used to be something called Cover the Uninsured Day, where one of the foundations tried to set up one day a year where everybody across the nation in communities would talk about the importance of covering people. There was a group called Healthcare Action Now, or HCAN, that convened like hundreds of advocacy groups to try to say, how do we share information and come together for action? And then there were the strange bedfellow groups, the ones that are unusual, like the same people who created those Harry and Louise ads back in the 1990s, agreed that they went too far. So they teamed with a group called Families USA to develop their own kind of like coalition to try to advocate for health reform. I work for a coalition called Better Healthcare Together, which was Walmart and AT&T, as well as the unions, SEIU and AFL. And the leaders of those organizations, their CEOs, the CEO of Walmart would go up and talk to members of Congress and leadership saying why we need to do this, right? So that had to happen to create that kind of organized effort to move forward, as well as political momentum. I mean, policy doesn't happen in a vacuum. It happens in a political environment. How do you convince people that it was not that political third rail? Well, we had some help from Mitt Romney, who was then governor of Massachusetts, who, with the backing of the Democratic legislature in Massachusetts with Senator Kennedy's support, passed universal health care in Massachusetts. Massachusetts remains the state in the nation with the lowest uninsured rate. What they did then still exists today, and it worked. We also worked hard, and this is a lot of people, the same coalitions we just talked about, to make it a viable issue in 2006. There was a midterm election, George Bush was still president, but there were people out there running on this issue of health reform, and people like my organization, others, that were doing candidate forums. Put people in front of a room like this for an hour and say, what would you do to fix our healthcare system? As simple as that, and begin to get people comfortable with the ideas and the need to do it. And indeed, what we found is after that election, it was a major issue. And Nancy Pelosi, who became Speaker of the House of Representatives, gave credit to the fact that health reform was important, it's out there, and we need to get ready for it. And then the last political momentum before we get to 2009 was, we had a Democratic presidential candidates forum, Center for American Progress, other organizations sponsored it. We had a full day with every Democratic primary candidate talking for a half an hour, 45 minutes with a reporter about their views on health reform. Now, it doesn't happen anymore. Think about the last presidential election. There were barely any primary debates. There was one, presidential candidates debate. Back then, we had a whole day dedicated to nothing but health reform, which again creates this idea of political momentum, inevitability, and need. So indeed, the door opened. In the 2008 election, Obama, then Senator, won. The Democrats gained a sizable majority in Congress. They got the Senate as well as the House. There was a readiness for all the work that we just talked about. I was on the transition team and was the person who probably not smartly set up the first health reform meeting the day after the election at 9 o'clock when nobody was coming. They were all doing something else at 9 o'clock the day after the election. But we were ready to go. And then by the time we got to 2009, and this is going to be a very light touch on everything that happened to pass the Affordable Care Act, there was a White House forum where literally almost every member of Congress came, Republicans and Democrats. Ted Kennedy was still alive. He came. We had all the stakeholders. It was a robust discussion, not of whether we're doing health reform, but how we're doing it. The president realized we had to get doctors on board. I mean, it was a big problem in the past. So he actually went to the AMA's annual meeting and spoke to them about the need to get on board and the importance of health reform. And at that point, I think he had a very receptive audience. But then what happened was in September, he did go to Congress and did a joint address to Congress. It's a rare thing outside of the States of the Union for presidents to go and say, I want to talk to you all. But as we'll talk about in a second, we were started hitting headwinds and he really felt the need to galvanize people. And just again, underscoring the effort that President Obama put into it. When things weren't going so well the next year in February, he held a summit again with the leaders of Congress at the Blair House, which is the house across the street from the White House, to really try to congeal things. He engaged, we engaged, lots of activity going on. But the timing was not all that great. We had hit a recession in the fall of 2008, didn't quite know it, but the automakers were going bankrupt, banks were going bankrupt. We had competing demands. People really said, no, we should do climate change first. We should do immigration first. We should do other things that were on the list that hadn't been done under the Bush presidency while we had the moment. That slowed things down, as did the increased politicization. So all that bipartisan support that we had a few years ago began to taper. Mitch McConnell, then newly the Senate Minority Leader, said, we can't support this president because if we give him a major victory, then it'll be a Democratic majority for a decade. That kind of politicization, which is not about policy, but about politics. And then, we had the Tea Party that arose. You might all know the story, but I think for physicians, it's always interesting. One of the provisions in the House bill, not yet passed the House, was paying for end-of-life counseling. Just trying to say it's a service that should be reimbursed by Medicare to spend a certain amount of time with somebody who is potentially in hospice care, et cetera. That became death panels. The death panels were some government official is going to be in charge of pulling the plug should you be in a hospital or be in a hospice, which is inaccurate, but that was the theme of the August recess, which saw a beginning of a major pushback against health reform. And then we hit a real problem with, after Senator Kennedy died in August, his seat was open. It got lost to Scott Brown, a Republican, which meant we didn't have the votes. So there was a long hiatus after that in which there was a thought that it would never happen. But Nancy Pelosi and the president and Harry Reid felt very strongly about it, and they pushed it through. We will not talk about a lot of the drama around that, but we'll just go to the passage passed in March of 2010. One of the lesser known facts about the Affordable Care Act is it does have 10 titles, meaning sections of the law. The first 3 are the ones that people focus on. How do you make coverage affordable? How do you ensure public programs are up to it? And then how do you improve efficiency? Those are just 3 of the titles. But if you look at the next 3, for example, it was prevention of chronic disease, public health, workforce. There's a whole title of the Affordable Care Act on workforce, as well as on program integrity. those could be the same chapters that we see in bills today. They were in there as well, but get lesser attention and were not as funded as we would have liked them to be. So it was big. It had lots of pieces of it. And at the time, the Congressional Budget Office, which was the official scorekeeper, projected that it would cover 95% of Americans. It would be fully paid for, meaning we actually were able to take funding from the health system and certain targeted taxes and reinvest it back into coverage. And I'll just tell you something, at that point, all the doctors, American Hospital Association, they all supported it because they wanted the money in the system to shore up and rebalance what was an imbalanced system. And we also did get credit for slowing the growth of healthcare. So that was the moment the bill got signed into law. But the same day that the bill got signed into law, things started happening. So this is going to be the whirlwind tour of 2010 to 2016 while President Obama was still in office. I'll do the bottom part first, which is the day the bill was signed into law, we got sued. A guy named Ken Cuccinelli from Virginia began a lawsuit that hit the Supreme Court in 2012. That fall, because of, again, that backlash that began, it really did build up. In the fall of 2010, the Congress flipped. So it went from being a democratically led Senate and House to being a Republican-led Senate and House, which meant the first bill, H.R. 1 in 2011, was repeal the Affordable Care Act. That was the first of, there's been 60, I think, by somebody's count, efforts to repeal the law since that moment. President Obama had to veto like 40 of them, I think, because they just kept putting it on things after things and this way and that way. But that was certainly the priority for the Republicans at that time. That case that got filed on the day that the law was signed got to the Supreme Court and was decided in June of 2012. I'll just say there were four parts of the litigation, but I'll just talk about three of them. One was that individual mandate that I mentioned before, that if you can afford it, you have to have coverage. That was viewed as unconstitutional. As Scalia said at the time, it's like forcing somebody to eat broccoli. You can't do that, but Justice Roberts did find that it was constitutional under a taxing provision. A second policy that was in the same litigation was that Medicaid floor. So the Affordable Care Act did create a floor that all states must cover people with income below 138% of the federal poverty level. That was a requirement in the law due to be effective in 2014. But the Supreme Court in that case actually said, no, that's coercion. You can't force a state to do that. So that Medicaid floor became a state option. And the third part of that litigation that matters because it really shows you just the challenges of drafting legislation was what's called the severability clause. What that means is if one part of the law is struck down by the courts, if there's a severability clause, it can be severed or like taken out of the law and the rest of the law is fine. There was not a severability clause in the Affordable Care Act. So there was this view that if one piece of it is unconstitutional, the whole law goes down. And I bring that up just because, again, going back to kind of the threats that happen, if Justice Roberts had said, yes, the individual mandate is unconstitutional, it's a violation of interstate commerce clause, blah, blah, blah. If he had done that and they said there was no severability clause, the entire law would have been struck down within 30 days. Entire law, meaning the drug discount cards that were out there, accountable care organizations. We were providing coverage to people with pre-existing conditions in a program at that point. All of that would have had to be unplugged in 30 days. Just shows you the vitriol that was happening. People were willing to take down even popular parts of the law. One of the popular parts of the law was covering adult dependents on their parents' plans. That took effect within 6 months of the law. That was one of those early deliverables that are in the top chart, part of the chart, but that was what was at stake. I'll do the last negative and then I'll fast forward to the positives, which is, the same time after we survived the repeals, we survived the Supreme Court, because we did survive the Supreme Court in that particular day, we went to launch the big health insurance reforms. Again, many books have been written about it, but the website called healthcare.gov did not work. It was a big failure, lots of reasons why it didn't happen. But I think the flip side of it, there was a true teamwork recovery effort that included getting people signed up in different ways, using the telephone, using community-based organizations, and we did get it up and going to the point where after, again, these early deliverables that happened in 2010 before the big reforms kicked in, We launched on January 1. People were covered, and we actually hit the 8 million people we were trying to get in year one that we predicted in 2010 in April of 2014. So it was working with lots of setbacks. By the time we got to 2016, because remember the Medicaid part of it was now optional, we did get 32 states that expanded Medicaid, but not all the states. But as a reminder, this began with HR 1 repealing the Affordable Care Act. That was the perennial, policy of the Republican Congress. We didn't get any fixes in Congress from 2011 through the end of the Obama administration. So now it's 2017, and it's a President Trump who is in office. Congress said, yes, now we have a president who supports our priorities. Time to repeal the Affordable Care Act. But they hadn't quite done all that work I talked about earlier that we did to pass the Affordable Care Act. And so they didn't have actually a replacement policy. They wanted to repeal it, but what comes next? And you can't at that point rip out a system that has actually affected Medicare, Medicaid, private insurance, you name it. Lots of parts of our healthcare system were affected by then. So they first tried this repeal and delay, like repeal it for a couple of years and then figure out what comes next. That didn't last. Then they had a repeal and replace bill, but it's just kind of skinny bill that was pared down and not well thought through. Back in those days, there were lots of senators and Congress people who said, what will this mean? How many people will be affected? What will it mean for costs? And they wouldn't vote till they got it. So Congressional Budget Office, again, did its work, and they came up with an estimate that this repeal and replace bill would mean 20 million people would become uninsured. That meant my senator from Maine, Susan Collins, voted against it. Lisa Murkowski from Alaska voted against it. And after earlier in the day, going to a press conference with Lindsey Graham, saying he was going to work on a bill to replace the Affordable Care Act, Senator McCain at 2 a.m. in the morning did a thumbs down vote, which meant that that bill was dead. Lots of history again about why Senator McCain did that. He's talked about that. I know President Obama talked to him after that vote to talk about his courage and bravery in taking that vote, but it never really resurfaced. So that was an effort. Again, we go from pendulum from Clinton tried, failed, Gingrich tried, failed. We get a little bit of children's health insurance program. Obama succeeds. Trump in the first time he was there failed, but now it gets a little bit more interesting. So you all now remember this is recent memory, when COVID-19 hit, we had actually another little spurt of health reform. Part of it was the widely available and free vaccines and testing that were associated with COVID-19. Even today, as we're going into this fall, you see people wanting that. They appreciated that that was a valuable part of what happened in the 2020, 2021 period of time. That was out there and made a difference in public health. So too did the Medicaid policy originally passed under President Trump, which said that during a pandemic, we will not remove people from Medicaid program. So if you were on, you stayed on. It's called continuous eligibility. Didn't think it would last from 2020 to 2023 because the pandemic lasted longer than any of us thought it would, right? But people stayed covered. Again, it mattered in Medicaid, which meant Medicaid coverage went up. When we started making sure those people were actually eligible in 2023, 2024, we really started focusing on, wait a minute, our Medicaid system is way too complicated. So there's actually this whole wave of reforms in the past couple of years to make Medicaid eligibility simpler. And we almost, during that period of time, and people just forget this, almost allowed the health insurance marketplace to drop its eligibility to fill in the gap in Medicaid where states hadn't expanded. Texas, Florida, Georgia, these are states, they're big states. And because they hadn't expanded Medicaid, there are all these people between, you name it, 15% of poverty and 100% of poverty who are not eligible for anything. If you're at 101% of poverty, you're eligible for the ACA marketplace. And you're 99% of poverty in these states, you're not. So we almost got that, but didn't quite under the Biden administration with a Democratic Congress with a slim majority. There was also an improvement in the Affordable Care Act's enhanced premium tax credits. This is in the news today, so I'll spend a second on it. What that law did, American Rescue Plan extended by Inflation Reduction Act, was to take the upper income eligibility cap off of marketplace coverage and smooth it out. It also increased the tax credits for low-income people. So that yellow line is the original ACA. That's a percent of income that people pay. for their health insurance. And you can see that yellow line jumps. That's at 400% poverty, where all of a sudden you're cut off, right? It's a cliff. The new policy, the enhanced subsidies, just phases out naturally at 8.5% of income. And that's what's in place today that will end at the end of the year. So we had a little mini health reform in recent times. But I'll talk a little bit about what's happened this year because I think it matters for our discussion. So in December, President Trump gave an interview on Meet the Press saying, no, 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 I'm not going to repeal the Affordable Care Act again. Been there, done it. Unless somebody comes to me with a better idea, unless somebody has a plan to do it, I'm not going to do it. That's what he said. Indeed, when you talk about the budget reconciliation law that passed in July, also formerly known as the One Big Beautiful Bill Act, it extended those huge tax cuts that Trump had enacted in his first term in 2017, also included funding for defense and ICE and Homeland Security. It did not include extending those tax credits I just discussed. It could have, but it didn't. And it partially paid for all those tax cuts through rollback of all the Biden administration climate tax cuts, as well as pretty deep cuts to nutrition programs, the SNAP program, higher ed, as well as healthcare. Now, again, there's claims that it was not health reform. Talk to proponents, even like Mehmet Oz, will say we didn't change the structure of any of the programs. We didn't change benefits. We didn't change eligibility except for legal immigrants. And we can talk about that if you're interested in it, but they definitely did. Cut back on eligibility for people who are legally immigrants in this country. They argue that the new work requirements in Medicaid are justified to make Medicaid an earned benefit, which for all the states that just simplified their Medicaid programs, it feels like a pendulum swinging the other direction. And a lot of their argument about where these savings are coming from is program integrity. The wrong people are signed up. People are ripping off the system. Mostly people, not healthcare providers, not hospitals, not drug companies. In fact, there's no drug company savings at all in this bill. There's no insurance company savings at all in this bill. It's all really coming from, as I'll say in a minute, these different policies. They also blame states. So there's a real pushback on state financing. You'll see next year states coming into session to try to figure out what to do about the reduction in federal funding coming to states to run their health programs. But I will just say, as I finish up this history section, the One Big Beautiful Bill Act was almost as big as the Affordable Care Act. Over $1 trillion over 10 years in healthcare cuts, the largest cuts in US history in our healthcare system. Did they target the ACA? Indirectly. So going back to the marketplace, between not extending those tax credits and the cuts that they made, there is a 40% reduction in support for people getting marketplace health insurance through these actions. On the Medicaid front, KFF, which is Kaiser Family Foundation, did a rack up and found that 58% of all those Medicaid cuts, which is like $900 billion, are only applying to the ACA expansion states. So is it a repeal of the ACA? Depends on how you look at it. Certainly harms the Affordable Care Act. And then again, going back to goals, what was a main goal of the Affordable Care Act? Covering people. This law and all the actions related to it will increase, according to the Congressional Budget Office, the number of uninsured Americans by 50% by 2035. 10 million more uninsured from the bill, as well as 4 million more from the lapse of the tax credits. So I won't go into this chart on the right because it's itty bitty and you probably can't see it. But the idea here is, these are two big health reform bills. Are they the same? And, the ACA, we spent a whole lot of time getting public input, 7 White House forums. We accepted 153 bipartisan amendments, Republican amendments. We had some popular support, not a lot, but certainly more than the GOP bill that came through. And again, we see the diametrical opposites. ACA expanded coverage by 32 million people. This will reduce it by 15 million people. ACA reduced the deficit by $143 billion. The Big Beautiful Act will increase the deficit by $2.4 trillion. That was a piece of unsuccessful advocacy that I tried to do before the bill passed. Did not make a difference, and we could talk about that. But before we get to that, just as a quick reminder, we don't yet have all the data from this year. We're still in this year. These are all very, very recent changes. But Census Bureau came out yesterday with its update of the uninsured rate. We're still at a record low uninsured rate. That's partly thanks to the ACA, for sure. You can see the line drop, but also due to some of the recent improvements. We also can track that it's not just coverage, it is access that's improved, although, we've seen some fraying in that, but it really did come close to achieving its goal. And if we actually had been able to keep that Medicaid floor across the nation, I think we would have been there. We also did make a difference in healthcare costs, although there's lots of scholarship and debate about this. This chart shows you just the fact. The percent of health spending, or excuse me, our economy's percent, the percent of our economy spent on health spending has not really increased. It blipped during the pandemic, but it hasn't really increased since the law was passed. If I go back further, there's a line that shows like this. It was going up, 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 and then it stabilized. It's begun to change a little bit. We're now seeing a resurgence in healthcare costs, and it's difficult to parse out, but I think most people think that there were some of those elements of the ACA that did make a difference. But let me turn to surprises. One of the surprises is that it made a difference despite all the repeals that happened after the law passed. So almost anything that was controversial that saved money kind of went away. Over 24 provisions were repealed at some point in the past 15 years, including one, which is a tax on the most generous health plans. The Congress limited some of our innovative so-called game changer ideas, like the Center for Medicare Medicaid Innovation, and even some of the policies that we thought would save, like by cutting Medicare Advantage payment rates, ended up costing money because there were workarounds and ways around it. Again, if you don't pay attention, nobody improving a bill or a law or anything over 8-10 years is bound to have holes in it, and that's what's been happening. But we still got savings. We also were surprised by the extra effectiveness of those premium tax credits. This goes back to that preparation work. We really thought and worked hard on would this design work, and indeed it was adaptive when an administrative action in 2017 cut off a major source of funding for these cost-sharing subsidies. The premium tax credits rebounded. And then after the Inflation Reduction Act and American Rescue Plan bumped up those credits and got rid of that cliff, we saw a climb. It's almost double the enrollment of what it was just 4 years ago, showing that public policy can work. We also discovered the hard way that the individual mandate was not essential after all. Of that three-legged stool, it was the hardest one for everybody to accept. People don't like to be told what to do, but we looked at the experience in Massachusetts. We have lots of research on seatbelt laws. The laws working incentives don't. So that was why we did it. The insurance companies demanded it. They say, if we're going to have to take all those people with pre-existing conditions, you need to make sure all those healthy people come in to balance it out. They said we had to have it. And the Supreme Court almost took down the whole law because of it. But in that same tax cut bill that Trump just extended in July, they got rid of the tax part of the individual mandate. So it's basically a toothless mandate because nobody gets taxed if they don't have health insurance. Hard to know how much that has affected things. 4 states came back in and reinstated it. They have the lowest uninsured rates in the nation, but we had a lot of stuff going on. Needless to say, I think most people agree that it was not the linchpin of the Affordable Care Act that we thought it was, and probably would not have put it in if we had known that. We also discovered, and I'll just do a tiny bit of an aside on this because I think it matters. There were lots of policies in the Affordable Care Act. Nancy Pelosi used to get laughed at for saying, you have to read it once we pass it because it's just a big bill. Some of them were meant to try to fill gaps in until the systems took place. So I talked about those early deliverables. One was this pre-existing condition insurance program. After saying our whole goal is to help people who are uninsured, who have cancer or a history of illness, get coverage, we couldn't say, it's okay, wait till 2014. It was 2010. So what we built into the law is a temporary program that we literally stood up in August 2010, ended as soon as the marketplace began. We counted up 1,600 actions to run this program. And the chart on the right shows the swings in spending. It was a very volatile program. We had 135,000 people who were uninsured who were helped. And period, if that's what it was worth it. That's always my belief. But as a lesson, compare that to just changing the rules for people with pre-existing conditions. That part of the law was 1 page of law and regulation text. The insurance companies actually said it's easier for them to implement that than to have underwriting and look at people's applications and try to go through the whole screening for people with pre-existing conditions. And 3.9 million people who were uninsured who had a pre-existing condition gained coverage. Sometimes you have to go the simple approach, even if it's bigger and more dramatic, to fix what exists rather than create something new. So then turning to lessons, and I'm almost done talking because I want to make sure we have time for questions. What do we learn about health reform from this very interesting saga, right? One, from my viewpoint, is be ready. Do the work. You have to do the work. I mean, I think if the Republicans had done their homework before 2017, when they had the window open to do their own repeal and replace, they might have had a viable replacement alternative for the Affordable Care Act, but they didn't. But it can't be just a good idea. There's many, many good ideas on how to improve our health system. I love some of the ideas out there, but it has to be comprehensive, coherent, and workable. And that's something that people just need to work on. And that can only be done, in my second point, as with a consensus. You can't do this by yourself. It can't be one person or one congressperson or one advocacy group. It really took everybody being on board, including the people who had to give something to get it. Again, American Medical Association, Hospital Association, even Pharmaceutical Association gave part of the funding for the Affordable Care Act to get to where we need to do. That needs to happen. And then just trying to figure out a viable way forward. You can't just have here's my plan and I'm pushing for it. Here's my plan, here's plan B, here's plan C, and here's ways that if we're stuck in a, dead end, how do we get out of that and keep going? That kind of flexibility is something that's hard for some policy people to do because they really find their idea and they love their idea and they don't want to give it up. But sometimes you have to move forward towards a big goal like universal coverage. And just in terms of readiness, I think this value point is underappreciated and important, especially now where people don't trust science. They don't trust everybody's estimates. I mean, even the Congressional Budget Office, which was so important in the Affordable Care Act and in 2017 in the repeal and replace debate, the Congress voted on the One Big Beautiful Bill Act 2 weeks before the Congressional Budget Office finished its analysis. They didn't even wait. They just did it. So values matters because we don't have the same kind of trust in the traditional ways of thinking about things that we used to. And then when in the throes of trying to make this happen, we did a lot of compromises in the Affordable Care Act that we did thinking it might attract Republicans. We didn't attract Republicans. It wasn't worth it. So, I think we learned some hard lessons about how to compromise in that process. We also realized the incredible importance of focusing on the fundamentals. Get the core and the strength and the foundation right, because then it'll hopefully endure over this kind of very traumatic period of time, like those tax credits. I definitely think that we should all think about improving what exists rather than creating something new. We have a lot of health coverage programs in the United States of America, probably too many. Can we simplify them, align them, really try to make the system simpler? Because I am convinced that complexity in our current healthcare system is itself a problem, a major problem that is keeping people away from needed care. And then just recognizing that securing even small changes sometimes is just as hard as the big ones. I gave you the example of that little program, pre-existing conditioning program. I can name dozens of them. Children's health insurance program. I worked on it. It was I was responsible for it at the White House in 1997 through 2000. I loved CHIP. But could we have done more and bigger with the same effort and more outcomes? That's the sort of thing you have to begin to think about. Is the small policy worth it when you might be able to, with just a little bit more challenge or work or coalition building, get something big? So I am going to try to leave with a little bit of hope because when I left my job in Maine last June, it was to get ready for health reform one way or the other. That's why I left my job. One way was because I had been in the White House in 2016 and my job was to prepare what if Trump won. So I was prepared. I was the only one prepared. So the same day after the election in 2016, there were definitely people who didn't want to come to work and did not want to be in my office like the same day after the election in 2008. But I was ready with a plan and this is what we do and this is how we do it because we were ready for that, right? I say fast forward because I think a year ago, I would have said we'd be ready for Trump. And I think people have been sort of ready, although it's been different than I think any of us ever imagined. But I also want to prepare for the next moment. Where are our big ideas? Do we have the coalitions? Do we have the numbers? Where are we in terms of readiness should the window open like it did in 2008, right? That window is going to open sooner than we think. And I think so for a couple of reasons. Number one, premiums are going up. That's what people care about. When they see a price tag that with general inflation being 3%, employer premiums next year are going up by 3 times that amount, by 9%. The individual marketplace, because of everything going on, is going up by 18% and rising. That's sticker shock. When we see the Part B Medicare premiums this fall, mark my words, are also going to be up. We're seeing that kind of moment where people are saying, do something about this system. Medical bills and medical debt are really reaching a crisis point. Prior authorization is something that even yesterday in the divided House of Representatives, there was an amendment that got agreed to in the Labor Relations Committee to say, we need to do something about prior authorization. We have some opportunities coming up. And we also know that states are going to have to act. Going back to the cautious states, they're going to have to do something next year. They have no choice. So they may be looking at ideas, and we're very close to a midterm and a presidential election. So I say all that because, looking at the past, you can't always extrapolate from the past. There are different people. There's a different world of social media, different idea of what the presidency is these days and what Congress should be doing. But we've seen it before. We'll see it again. There will be health reform. It's a question of what it is and when it will come. And I am cautiously optimistic that positive health reform is on the way. So with that, I will stop with 10 minutes left to be able to answer questions. All right, who wants to go first? Yes.
Maureen Tierney, I'm actually a PH Chan alum.
There you go.
Yes. In terms of premiums, I think we've gone a lot of converting flexible Medicare is now going to be a trial of prior authorization.
I think that's one thing that's actually gonna shake a lot of the population over 65 up. What is your?
Yeah, I mean, not just a trial of product. Did everybody hear that question? Should I repeat it? Okay, I'll repeat it. Traditional Medicare is going to be doing a trial of prior authorization. What do you think about that? And I'll just add, it's not just a trial of prior authorization, of AI prior authorization, which I think also adds some element to it. I think there's no good answer about who is the judge of what is appropriate care, right? We all like to think it's you with your patient, knowing circumstances, knowing history, knowing records, should make that choice. There's skepticism by some insurance companies, even maybe Medicare, to say, is that an appropriate choice? Or is the patient asking for too much? Is the provider prescribing too much or ordering too many tests or doing too many things? That's why we have this. There's no, I think, good answer to that except for clinical deference, which we tried to do in the past, which is eroding these days. But I do think that that is going to be a catalyst for change. We're going to see some change. I think people are really upset. I mean, I didn't show the chart or describe the chart that I just was on the screen, but 44% of people in July of 2025 think it's difficult to afford care. I mean, that's a system that, proud of everything we did in the Affordable Care Act to get people covered, but that coverage now is like Swiss cheese where there's holes in it and there's workarounds, and without being able to attend to it and fix it and think about, like, wait a minute, maybe we should have done something different, it's eroded. And it's time to fix that, which is part of the reason why I left my old job to work on that. Because as much as I love Maine and would like to be doing what I used to be doing in Maine, this matters. Yes.
How do you see, like, this is obviously in the public eye. How do you see the death of Brian Thompson and the whole him getting transported to a hospital that was dropped by UHC affecting how the political environment sort of prioritizes healthcare and healthcare reform?
And for those of you who didn't hear, how does the situation with Brian Thompson and UHC, him being transferred to the hospital, not in UHC's network, affect the current environment? It is definitely on everybody's mind. I mean, it's kind of surprising how that, I'll call it, thread of anger and upset kind of connected a whole lot of people in different places. Again, it could be a catalyst, but for what? This is where my worry is that there's not enough good hard thinking policy wise, coalition wise, for what does that mean? How do we address that concern? It could be insurance profitability. It could be, trying to get rid of prior authorizations. It could be trying to get rid of middlemen. There's lots of ideas out there to address it. I think we need to have a greater idea of big ideas that are simpler to try to address that. But I will just say, going back to kind of the one big beautiful bill, states next year will be looking at insurance companies because they didn't get hit in this one big beautiful bill act, right? Like Could there be more oversight of insurance companies? Could they save some more money by looking beneath the hood to see what is the overhead, what's going on in insurance companies? Can we save money there? As well as drug companies, because drug companies, there was not only no savings in one big beautiful bill from pharmaceuticals, they expanded a loophole so that Medicare drug negotiation won't include certain orphan drugs. So it actually got worse, not better, in one big beautiful bill. But I think the answer is it will catalyze things. Exactly what, I'm not positive yet. I'm hoping it's bigger ideas, but this Congress probably won't do anything on it. Except they did an amendment yesterday in Labor Agencies Committee. Let's start here.
Yeah. Can you just give an example of a good bipartisan coalition that has a chance of doing anything?
Right now,
Yeah.
give me a second. I can't think of anything off the top of my mind. It's hard. We're in a very polarized, environment right now, but I will say it's beginning. There's a beginning of it. I will just say that, because I do think that going back, and I think coalition building is a tough one. I mean, back in 2002, 2003, there was a meeting in Herndon, Virginia, which is kind of a place outside of Washington, where somebody decided to bring together like very diverse set of people, different representations, different political parties, everything. And it was a very focused effort. Like, do we believe that everybody should get covered? And everybody had to, that was like your entry ticket, right? They did. But then it was a working conference about how we do this together. I think we want to fast forward. That's what we have to build today. I don't think it exists today. I think it can. And I think what just happened is going to catalyze on that. That's the best answer I can give you, I think. The one right there and the over there.
So I can't remember what they're called, but that agency or that's between the insurance company and the pharmacy.
Pharmaceutical benefit managers,
There you go.
PBMs.
So what is anything that was it created because of the ACA, or was it just happened and I know that they all of a sudden realized they could make money and that's what happened there.
Yeah, it was just, I mean, this is where some people would argue that we need more regulation to prevent that from happening. It was the following, is that drugs basically are commodities that can be negotiated. And these companies came along and say, hey, for you, and you, if you let me negotiate on your behalf, I'll get you bigger discounts. Sounds great. But what they ended up doing is charging you, and you some percent of the drug costs. So they actually had an incentive because they get higher percent, higher payment, higher the drug to negotiate some special deal with the pharmaceutical industry. And that's what's happened. And we're now down to like 2 or 3 of them that are dominating the country. There is talk in Congress about doing something about it. Something is kind of like transparency, which is a word that these days I'm kind of over because I don't think it means much. But there's definitely people trying to think through what are alternatives to PBMs as a way to negotiate prices. Again, Medicare negotiations in its trial phase, we're now ramping up from 10 to 15 drugs. This administration's continuing to do it. There may be some more. So, yep.
Thanks so much for an excellent talk. As a surgical oncologist, I was part of a team that did policy evaluation on the unintended consequences of ACA for access to surgical care. There was a consistent trend that access to surgery or cancer surgery, especially among minoritized, low income or rural population, did not change significantly or sustain itself. Insights from your perspective.
There was always a concern before health reform passed that bringing 30 odd million people into the system will strain capacity and will make it harder for currently insured people to get care. That was a strain throughout. We actually did in the early days of the Affordable Care Act bump up payment rates to kind of improve and sustain access. We tried to improve that kind of capacity. May or may not have worked, but I'll go back to the Supreme Court not eliminating the mandate for Medicaid expansion. We still have, depending on who you count, like 2 million people who are uninsured in that Medicaid gap, who probably are in that kind of group that have not been helped. But I'll flip it around. We have very good kind of case control studies of expansion states that do show that states that did expand Medicaid under the ACA have had better outcomes for those disadvantaged populations. So it's a mixed literature.
Actually, I'm talking about expansion states that we didn't see that bump coverage.
Yeah, I don't know the research, so I can look into that. Thank you.
We do have one online question that we'd like to pose.
Okay.
And I think Ashley's
Sure.
gonna ask.
Yep, I'll read it on Dr. Sikowski's behalf. He says, has or will Medicare Advantage produce any cost savings compared to traditional Medicare?
The Medicare Payment Advisory Committee, which annually puts out a report that really looks hard at where there's opportunity, says that there's room to cut Medicare Advantage and maintain its viability in the system. I kind of wish they had done that in the bill that passed this summer versus Medicaid work requirements and cost shifts to states. So I think there's some room there. I mean, are there savings in the US healthcare system? Absolutely. Can we identify them, figure out a way to make the pain of that worth the gain on the other side? How do we use that funding? That's the trick. Question there?
Just when we talk about coverage, which is always a term that we use here.
Yep.
How meaningful a data point do you think that is from your work? Because anecdotally, I meet a lot of people that are covered, but that doesn't change their access at all. In fact, my own parents
Yep.
basically lost money when they were mandated to have insurance, and they said, "No, I'm paying money for an insurance that's not accessible." So like, is that a useful data point in general?
Yeah, and I think there is definitely some research that talks about, is all coverage equal? And the answer is no. But as a reminder, Medicare is also a really poor benefit. It's a 1965 benefit package, right? Like, we've tacked on Medicare Part D drugs. It still has high deductibles, doesn't have an out-of-pocket max, so you can just continue spending your whole retirement on Medicare. We definitely have variability. And cost sharing that's excessive does hurt access, period, full stop. So does bureaucracy, the prior authorization, so does kind of this random PBM kind of stuff. So yes, we need to harmonize and align our coverage rates, but the dichotomous covered, not covered still shows a greater difference in access than across within coverage, right? So it still matters more than being uninsured, but we definitely have room for improvement. That's why, again, this chart that I'm keeping up here is there, so. I haven't been looking over the other side of the room. Okay.
I think
You get the last question?
I might just pose the last question. And it has to do with the fact that we're a room filled with a lot of different health professionals.
Yep.
You have spent a career on both sides of advocacy, both bringing it in and
Being
advocating.
lobbied, yes.
What's your advice for providers in terms of their unique role or their non-unique role in health policy and advocacy?
Well, I will say to every healthcare provider, you have a disproportionate role because people trust you. I mean, there's still, again, in a world of distrust, people will listen to you more about health policy than they'll listen to me. Like, my PhD is good, but that's not who they want to hear from. They want to hear what you think. That means the fact that you're here and you're interested and you're engaged matters a lot. I have many friends who are health professionals, many of my own health professionals who are at various levels of knowledge, and being knowledgeable, I think, matters. It doesn't just matter for your engagement with your patients. It matters for your own understanding of the role and the practice within you, or excuse me, the system in which you operate. Understanding why am I being asked to do X, Y, or Z? Why is this happening? Why can't I get my patient referred to X, Y, or Z? It matters. So I think health policy matters a ton. And I'll go one step further. Again, President went to American Medical Association. We had a meeting in the Oval Office in September, October with key health professionals because we needed their help. Their voices, your voices, make a huge difference. So as you're thinking through that one-on-one intervention, that is what you're doing your jobs for. Both of my parents are health professionals, and that drove them and their values and their sense of purpose. Think also of the indirect, how do you help people by fixing the system that operates around you? So I do hope that you all stay involved, learn, because I think learning helps, and be a little hopeful, because I think some good changes on the way. Thank you.
Literally, we kicked off this health policy seminar series in a great way with a lot of expertise. Look forward to future policy seminar speakers, and thank you so much, Dr. Lambrew, for being there, for joining.
Thank you.